Imagine for a second that you're packing for a long trip. You've got one of those rigid, hard-shell suitcases.
Oh, yeah. The ones that do not stretch at all.
Exactly. And it is packed to the absolute brim, like zip shut, no give whatsoever. But then you suddenly realize you need to shove a heavy wool sweater in there.
Right, which is impossible without changing something else.
Yeah, there is just no negotiation with the physical space.
Yeah.
You want to put that sweater inside, you have to open the suitcase, take out a pair of shoes, and swap them out. You can't force more volume into a sealed, rigid box without something else giving way.
I mean, the physics of that system are entirely binary. It's a total zero-sum game of volume in versus volume out.
Right. Well, welcome to today's deep dive. We are thrilled you're joining us because today we are looking at a rigid box that you carry around with you every single day, your skull.
Yes, a very important box.
It's very important. We're pulling from a massive stack of sources today, spanning centuries of medical history, all the way up to, modern neurocritical care pathophysiology. And it's all focused on one incredibly high-stakes concept, which is increased intracranial pressure, or ICP.
Which is a fascinating and kind of terrifying topic.
It really is. So our mission for this deep dive is to explore the sheer mechanics of how swelling and bleeding interact with that rigid architecture of the skull. We're going to dispel some pretty persistent medical misconceptions and uncover why treating this has sparked, honestly, a profound ethical dilemma in modern medicine.
Yeah, the ethical side is where it gets really heavy.
It does. But, okay, let's unpack this, starting with the parameters of that hard-shell suitcase.
Right. So to understand what happens when intracranial dynamics fail, we first have to map out the rules of a healthy space. Like, what is normal?
Okay, so what is the baseline?
Well, in a healthy adult lying flat on their back, the normal pressure inside the skull is roughly between 7 and 15 millimeters of mercury.
Okay, so there is a baseline tension. Like, it's not a totally zero pressure environment in there.
Far from it, yeah. The system actually requires a certain amount of hydrostatic pressure just to function normally.
Gotcha.
However, once that ICP breaches, say, 20 to 22 millimeters of mercury, you cross a critical threshold. In neurocritical care, sustained pressure above that line correlates directly with severe secondary brain injury and, well, mortality.
Wow. So 20 to 22 is the danger zone.
Exactly. And to understand why that pressure spikes, we have to quantify what is actually occupying the space inside your head.
Right. The sources break the intracranial volume into three distinct compartments. So you have the brain tissue itself, which accounts for roughly 80% of the volume.
Right, the vast majority.
Yeah. And then you have the blood compartments, so arterial, venous, capillary beds taking up about 10%. And finally, the cerebrospinal fluid, or CSF, takes up that remaining 10%.
And this is where the suitcase analogy is perfect. Because the adult skull is fused and totally unyielding, the total sum of those volumes has to remain absolute.
No extra room.
None. So if the brain tissue swells, or, if a hematoma introduces new blood into the skull, one of the other compartments absolutely must shrink to make room.
And if it doesn't?
If the compensation fails, the pressure inside the vault increases dramatically. And this fundamental biomechanical rule was actually conceptualized over 2 centuries ago. It's called the Monroe-Kellie doctrine.
Right, named after Alexander Monroe, who was this anatomist in Edinburgh back in 1783.
Yeah, 1783. Think about that.
I mean, without any modern imaging, no pressure monitors, nothing. He basically just looked at the sheer anatomical density of the fused skull and deduced that, well, because brain tissue is essentially incompressible, the volume of blood circulating inside at any given time has to be constant.
Which was a brilliant deduction. But it was just a theory until George Kelly, another Edinburgh physician, provided the empirical proof a few decades later in 1824.
And his method was kind of intense, right?
Very intense. Kelly performed autopsies on soldiers and shipwreck victims. But crucially, he examined individuals who had died from severe systemic exsanguination. Basically, they bled to death.
Okay, wait, so Kelly is examining victims who bled to death systemically. Logically, you'd assume their brains would be totally drained of blood, just like the rest of their organs. Like, you'd expect a pale, bloodless brain, right?
You would absolutely expect that, based on how the rest of the vascular system works. But here is where the rigid box rule really shows its teeth.
Oh, wow. What did he find?
Kelly observed that no matter how massive the systemic blood loss was before they died, the cranial vaults of these victims still retained essentially their normal expected volume of blood.
Wait, really? The blood just stayed trapped in there?
Yeah. The rigid constraints of the skull prevented the intracranial blood from just passively draining away. The space is fixed, and, well, Nature abhors a vacuum.
That is wild. But I have to push back on this perfectly rigid box premise for just a second.
Sure, go ahead.
Is the skull perfectly rigid in all circumstances? Full stop.
Because I'm thinking of babies. And, don't their heads expand when they have fluid buildup?
That is such a good point, and it's a very common misconception. The perfectly rigid rule is heavily age-dependent.
Okay, so babies are the exception.
Exactly. Infants have open fontanelles and unfused cranial sutures. So when an infant develops hydrocephalus, the pathology often presents as a physically enlarging head circumference. The box literally just expands to accommodate the extra fluid.
Which is why it doesn't immediately cause a lethal pressure crisis for them.
Right, because the structural boundaries yield. But once those sutures fuse in early childhood, the vault is locked.
But even in adult, it can't be 100% hermetically sealed, right? There have to be holes.
Well, yeah, it's not entirely sealed. Even adults have small compliant channels. The biggest one is the foramen magnum at the base of the skull, where the brainstem transitions into the spinal cord.
Right, the opening for the spine. Yeah. And you also have emissary veins and the optic nerve sheaths. These tiny pathways do allow for some minute pressure venting, but for large, sudden shift in volume, the adult skull acts as an uncompromising vault.
Okay, so if the adult skull is this uncompromising vault, that raises a really tricky mechanical question about just surviving day-to-day life.
How so?
Well, if a person suffers a minor concussion with mild localized swelling, why isn't that immediate addition of volume just crush the brain against the skull instantly?
That is the big question. And the answer is that the brain survives those minor insults through a highly orchestrated compensation sequence. It basically buys time until the primary injury stabilizes.
How does it buy time?
Well, when new volume is added, say, a slow expanding mass, the body begins evicting the most easily movable occupants of the suitcase.
Okay, so it starts throwing things out.
First, it shunts cerebrospinal fluid out of the cranial vault, pushing it down through the foramen magnum and into the flexible sac surrounding the spinal cord.
Right, so it's literally taking the shoes out of the suitcase to make room for that extra sweater.
Precisely. And once the CSF displacement is totally maxed out, the next step is collapsing the veins. The body literally squeezes venous blood out of the dural sinuses and pushes it down the jugular veins into the neck.
Wow. Just wringing out the blood to make space.
Yeah. And this biomechanical spatial buffering was actually meticulously mapped out in the 1960s and 70s by a neurosurgeon named Thomas Langford.
Right, his experiments are in the sources. He used animal models, right?
He did. He inflated tiny epidural balloons inside animal skulls at a very controlled rate to simulate a growing hematoma, and then he just recorded the resulting pressure changes.
And Langford's data gives us the compliance curve, which honestly is one of the most mechanically terrifying concepts we came across in these sources.
It really is, because it is not a linear, gradual progression.
Right, it doesn't just slowly tick up.
No, the compliance curve is exponential. If you plot volume on the x-axis and pressure on the y-axis, the initial phase of the curve stays almost completely flat.
So you're adding volume, but the pressure isn't rising.
Exactly. You are continuously inflating the balloon, adding substantial volume to the rigid box. But the intracranial pressure barely moves. That flat line is the spatial compensation working perfectly. CSF and venous blood are leaving the vault at the exact rate the balloon is expanding.
But you inevitably run out of space.
Yes, you hit the inflection point. The moment the buffering reserve is totally exhausted, the very next milliliter of volume added to that balloon causes the pressure curve to go nearly vertical.
That's terrifying. So the exact same tiny drop of volume that was easily absorbed 10 minutes ago now triggers a massive catastrophic pressure spike.
Exactly, which means the rate of expansion dictates absolutely everything about survival.
Right, because a patient with a really slow-growing brain tumor like meningioma, they might compensate for months. Their body incrementally clears space, and neurologically, they seem totally fine.
But an acute arterial bleed of the exact same physical size overwhelms the system in an hour. The tragic case of the actress Natasha Richardson in 2009 perfectly illustrates this specific trap.
Yeah, that story's so sad. She took a minor fall while skiing, right?
She did. She sustained what appeared to be a minor head impact, and she actually declined initial medical transport because she felt entirely normal.
And the sources call that the lucid interval.
Yes, the lucid interval.
Which is essentially a biological magic trick. The body is hiding the catastrophic crisis from you. So she was basically just walking along the flat part of Langford's compliance curve.
Exactly. She had a torn meningeal artery, which initiated an epidural hematoma. Arterial blood was actively pooling between her skull and the dura mater.
But she didn't feel it yet.
Because her brain was efficiently displacing CSF and venous blood, so her intracranial pressure stayed relatively stable. The compensation was masking the underlying hemorrhage.
But arterial bleeding doesn't stop.
No, it's relentless. And once she exhausted her spatial reserve and hit that vertical spike on the curve, the pressure multiplied exponentially, and it became fatal.
See, I have a question about this flat part of the curve. If the compensation mechanisms are hiding the core crisis so efficiently, isn't there some early warning sign?
You would think so, right?
Yeah, like what about a bad headache? You would assume that as a blood pool grows, even if pressure is technically stable, the patient would experience a progressively agonizing headache.
That is actually a very pervasive clinical misconception. A headache is an incredibly unreliable indicator of high intracranial pressure.
Wait, really? Unreliable?
Completely. The brain tissue itself, the parenchyma, contains no nociceptors at all. It literally cannot feel pain.
Oh, wow. I never realized that.
Yeah. The pain from high ICP typically comes from the stretching of the meninges or the blood vessels. But because the compensation curve adapts so smoothly early on, a lot of patients with critically elevated ICP experience only a mild headache or sometimes no headache whatsoever.
Wow. So the absence of pain gives this totally false sense of security. If you can't rely on a headache, what clinical sign actually betrays the rising pressure?
A much more specific diagnostic clue is papilledema.
Swollen optic discs, right?
Exactly. Remember those tiny compliant channels we discussed? One of them is the sheath surrounding the optic nerve.
Right, the venting pathways.
As pressure globally rises in the cranial vault, it forces cerebrospinal fluid down that sheath, which physically engorges the optic disc at the back of the eye.
Right.
A doctor can see that swelling directly with an ophthalmoscope, totally bypassing the patient's subjective feeling of pain.
Okay, so let's follow the timeline past that lucid interval. The compensation fails, the curve goes vertical, and the intracranial pressure skyrockets.
Right, the crisis phase.
The intuitive assumption is that the brain cells are just being physically crushed against the skull like grapes. But the sources point out this massive paradigm shift in neurocritical care over the last 50 years.
A huge shift. We moved from viewing pressure as a mechanical crushing force to viewing it as a vascular barrier.
Okay, what does that mean exactly?
Well, for decades, the field operated on the idea that pressure is the disease. But the modern understanding is that pressure endangers perfusion.
So it's not about squeezing the neurons to death, it's about starving them.
Exactly. Neurons are surprisingly resilient to uniform, static pressure. What they absolutely cannot survive is ischemia, a lack of blood flow.
Right.
High ICP drives down the cerebral perfusion pressure, or CPP. The equation for this is super straightforward. Your cerebral perfusion pressure equals your mean arterial pressure minus your intracranial pressure.
Okay, so the mean arterial pressure is the sheer force of the heart trying to pump oxygenated blood up into the head.
Yes.
But the intracranial pressure is actively pushing back against it. So if the pressure inside the box meets or exceeds the pressure coming from the heart, the blood literally just hits a wall.
The forward flow of blood completely ceases, and without continuous perfusion, oxygen and glucose delivery halts. The brain tissue starts to suffocate.
Wow.
So the primary mechanism of cellular death in these crises is ischemic starvation, not mechanical flattening.
And the crazy thing is, the brain is acutely aware of this impending starvation. The sources talk about Harvey Cushing demonstrating this way back in the early 1900s.
Yes, Cushing's experiments were groundbreaking. He was basically expanding on the Monroe-Kellie doctrine by recreating similar balloon inflation models in animals, but he integrated real-time monitoring of their systemic blood pressure.
So he could see how the body reacted to the brain starving?
Exactly. He observed the brain's desperate systemic response to localized ischemia.
Because as the balloon expanded and the local perfusion dropped, the brain panicked. It literally sent a massive sympathetic discharge to the heart and the blood vessels, demanding more force.
Right. We call this the Cushing reflex. The brain intentionally forces a massive spike in systemic blood pressure in this reflexive attempt to blast through the rising intracranial resistance. It's trying to restore that cerebral perfusion pressure.
Okay, so if the body intentionally does that, then is Cushing's triad, the classic combination of severe high blood pressure, a slow heart rate, and irregular breathing, is that the early alarm bell we were looking for?
Absolutely not. And that is another dangerous misconception that even gets taught sometimes. Treating Cushing's triad as an early warning is incredibly misguided.
Oh, really?
Yeah, it is a late pre-terminal physiological cascade.
Preterminal, wow. So by the time the heart rate drops and the breathing gets irregular, the window is closing.
It is rapidly closing. The bradycardia and irregular respirations indicate that the pressure has already overwhelmed the higher brain structures and is now physically compressing the brainstem.
The part that controls basic life support.
Exactly. By the time you see the full triad, spatial compensation has completely failed,
Yeah.
and you are basically witnessing impending brain herniation, where the tissue is physically pushing through the base of the skull.
Okay, so we've established how external trauma, like Natasha Richardson's epidural hematoma, introduces new volume and forces the system toward that herniation.
Right.
But the sources make it clear that the rigid box can also betray itself from the inside out without a single drop of new blood being spilled.
Oh, absolutely. Let's look at the three ways the compartments break. The pathology often originates within the brain tissue itself. A prime example is a malignant middle cerebral artery infarction.
Which is a massive stroke.
The massive stroke, yeah.
But a stroke is fundamentally a blockage of blood flow. It seems totally counterintuitive that a lack of blood would add volume to the cranial vault.
Right, but the added volume isn't blood, it's intracellular water.
Oh, okay.
When a massive stroke occludes oxygen delivery to a huge section of the brain, the ion pumps on the cellular membranes fail because they have no energy.
Right, they need oxygen to work.
So without those pumps, sodium passively floods into the neurons and water aggressively follows the sodium. We call this cytotoxic edema.
The brain cells themselves swell up.
Exactly. And because a malignant MCA stroke involves such a vast territory of tissue, the swelling brain becomes its own expanding mass, pushing that compliance curve vertical.
So that covers the brain compartment swelling. We already covered the blood compartment with traumatic brain injuries. What about the CSF compartment?
Right, the third compartment. Sometimes the pathology isn't trauma, and it isn't an ischemic stroke. The fluid dynamics themselves misfire.
The sources refer to this as idiopathic intracranial hypertension, or IIH.
Yes. This condition primarily affects obese females of childbearing age. And the presentation is baffling because the brain tissue is perfectly healthy and there is no hemorrhage.
No tumor, no bleed.
Nothing. Yet the intracranial pressure slowly rises well above 18 or 19 millimeters of mercury.
But how? If there's no mass and no bleed, how is the fluid creating a pressure crisis on its own?
It comes down to outflow resistance. CSF is normally absorbed back into the bloodstream through these structures called arachnoid granulations. In IIH, there is abnormal resistance at those drainage sites.
Like a clogged drain.
Exactly like a clogged drain. The fluid cannot drain efficiently, creating a mechanical backlog. The Monroe-Kellie doctrine is totally disrupted just by impaired fluid mechanics.
Wow. Okay, so going back to the stroke scenario for a second, if the stroke is making the brain compartment swell inexorably and the rigid skull is preventing any outward expansion, the biomechanical solution in the sources seems shockingly primitive.
Oh, you mean decompressive craniectomy?
Yeah, where you literally take a piece of the suitcase off to cheat the Monroe-Kellie rule.
That is exactly what it is. The neurosurgeon removes a massive bone flap from the skull and purposely leaves it off.
Leaving the brain exposed under the scalp.
Yeah. They also open the rigid duramater beneath it. It transforms a closed, fixed volume system into an open system. The swelling brain tissue is allowed to bulge outward beneath the scalp, rather than crushing inward against the brainstem.
I mean, it's a brutal violation of the vault's architecture, but it works, right? The sources cite the Decimal, Destiny, and Hamlet trials.
Yes, those trials from the 2000s demonstrated a definitive survival benefit for malignant stroke patients under the age of 60 who received this surgery rapidly.
It saves their lives.
It absolutely saves lives in that specific demographic.
Which brings us to the profound ethical flashpoint embedded in these sources.
Right, the really hard part of all this.
Because the mechanics of pressure and perfusion are clear. And the surgical ability to remove the skull and vent the pressure is well established. But clinical trials over the last decade have forced the medical community to ask a pretty devastating question. Does normalizing the pressure actually heal the patient?
And the transition from textbook theory to clinical reality here has been incredibly sobering.
Yeah, let's talk about the best trip trial in 2012.
Okay, so that was conducted across Bolivia and Ecuador. For decades before this, the standard protocol for severe traumatic brain injury involved drilling a burr hole and placing an invasive monitor directly into the brain tissue.
To measure the exact pressure.
Exactly. The operating logic was absolute. If you could track the exact ICP number in real time, you can aggressively medically manage that number, which surely leads to better outcomes.
It makes total sense logically, but Best Trip randomized severe TBI patients into two cohorts. One group got those advanced invasive monitors, and the other group was just managed using basic clinical exams and standard imaging.
And the results totally shook the foundations of neurocritical care.
What did they find?
There was no significant difference in functional outcomes or mortality between the two groups.
None?
None. Simply having a highly accurate measurement of the pressure didn't change the trajectory of the primary brain injury. Seeing the number doesn't magically fix the patient if the treatments triggered by that number aren't inherently restorative.
Wow. And if aggressively monitoring the number doesn't guarantee recovery, it really forces us to scrutinize that ultimate mechanical intervention we talked about, removing the skull for trauma patients.
Yes, this leads us to the Duskere trial in 2011 and the massive Rescue Eco trial published in 2016.
These trials looked at whether surgically removing a large portion of the skull for severe trauma patients actually provided a meaningful clinical benefit over just maximal medical management, right?
Yes, and the data presented a truly harrowing dichotomy. As a pure mechanical intervention, the surgery was an undeniable success. It reliably plummeted the pressure number.
To fix the plumbing.
It fixed the plumbing. And in the Rescue E trial, the surgery definitively reduced mortality. More patients survived.
So, to carry our analogy forward, we successfully unzipped the overpacked suitcase. The pressure was relieved. But the trial outcomes revealed that the items inside the suitcase were already permanently crushed.
Exactly. The primary brain injury, the initial shearing of the nerve fibers, the widespread cellular suffocation that happened before the surgery, you can't reverse that by simply removing the skull.
Right.
While Rescue Key showed reduced mortality, the survivors in the surgical cohort had substantially higher rates of vegetative states and severe disability compared to the medical group.
Oh, man. So the intervention literally converted imminent death into survival with profound, permanent neurological devastation.
That is the modern ethical burden at the bedside today. The trials definitively prove that treating the pressure number is functionally distinct from saving the mind.
We are succeeding as mechanics, but failing as healers. We're fixing a house that's already burned down.
That's a great way to put it. Clinicians and families are placed in this agonizing crucible. You have a patient with escalating pressure who will absolutely die without decompression. The surgery will likely save their biological life, but statistically it commits them to a life of complete dependency.
Unable to communicate or perform basic daily activities.
Right. And defining what constitutes a successful outcome in that scenario? Well, that's a deeply personal, philosophical question that a scalpel simply cannot answer.
Yeah, that is heavy. We have covered immense physiological ground today, and we want to thank you, the listener, for engaging with this intense material.
A lot to process.
It really is. We map the unyielding architecture of the Monroe-Kellie doctrine. We trace Langfit's exponential compliance curve, revealing how spatial compensation creates that deadly illusion of the lucid interval.
We explored the paradigm shift from mechanical crushing to ischemic starvation.
And finally, we confronted the harrowing ethical realities of the Rescue ACUP trial, where relieving the physical pressure does not always resurrect the person.
The physics of the cranial vault are absolute, but the human consequences of manipulating those physics remain infinitely complex.
Well said. But before we wrap up, I want to leave you with one final unexplored frontier that was mentioned in the literature.
Oh, right, the autoregulation piece.
Yes. Throughout this deep dive, the interventions we discussed were starkly physical, right? Drilling monitors, amputating bone flaps, chemically forcing the heart to pump harder. But the sources briefly touch on cerebral autoregulation.
Which is a healthy brain's intrinsic ability to smoothly adjust its own microvascular resistance.
Yeah.
It keeps blood flow perfectly constant across varying systemic pressures.
Exactly. But in severely injured brain tissue, that autoregulation breaks down. It leaves the brain entirely defenseless against pressure shifts. So here's the thought I want to leave you with. What if the future of treating head trauma isn't mechanical at all?
A totally different approach.
Right. What if the next era of medicine abandons the bone saws and instead focuses on neuropharmacology, finding a molecular mechanism to artificially reboot the brain's broken autoregulation?
Just equipping the cellular networks to weather the intracranial storm on their own terms.
Exactly. Rendering the rigid boundaries of the suitcase totally irrelevant. Something to think about the next time you marvel at the human body or, pack for a very long trip.
Safe travels.
Keep questioning the world around you, keep diving deep into the sources, and we'll catch you next time.